Okay, well, first of all, it's a real pleasure to be in Ireland, and thank you so much for inviting me to come here. Until 2011, I was a paediatrician and professor of child health in Leeds, and then made the move to Israel. And what I thought I'd do today was to have a think about obesity prevention in these two very different countries, and use it as an opportunity to reflect back on what works and the challenges involved in both. But let me start by telling you the story of Leeds. Leeds, as you know, is in the north of England, and this is a national child measurement programme data from when it was first initiated back in 2008. And Leeds had the pleasure, the privilege of being one of the highest obesity levels in the country. And when we look at the data, Leeds took this challenge seriously and decided that it was going to focus on really having a strategy that would attempt to tackle obesity seriously in childhood. And it implemented this obesity strategy in 2008-9. And as you can see, I wasn't actually involved myself, but the Public Health Department was delighted to see that at the start, the blue line is Leeds, started with very high levels, and over the next 8 years or so, the levels gradually dropped apart from a blip there in the middle. Nationally, obesity levels also went down, but you can see that it's a very, very gentle slope, and it seemed that Leeds had got on to something here. Now, what was this obesity strategy that was developed? First decisions were made. First of all, to focus on the preschool years, that if one was going to come in at any one point to really have an effect, that was the time to take action. There was a decision to focus on the most disadvantaged areas of Leeds, and in particular through working in children's centres, the Sure Start children's centres. The City Council was to work in partnership with the CCGs, and the intervention they decided to implement was a obesity prevention programme, HENRY. Now, Sarah, I have to say this is my most brilliant acronym, Health, Exercise, Nutrition for the Really Young, and it's sort of, I take pride in that. But the decision was taken to take a whole city approach and train every health visitor and all children's staff in the HENRY approach, and to date more than 1,200 have been trained. They're now shifting over to looking at the childcare workforce, both in private and public childcaring facilities, and it's extended more to community work, which has involved having volunteer parent champions to go out and have some community action. And so that was very pleasing results to see that coincidence with introducing an obesity strategy, there seemed to be an effect. Now, clearly, academically, this is not gold standard figures, but it is a coincidence, if you like, of public health figures with a citywide strategy. But let's go on to look at levels of deprivation, and this is where I think it's most stunning. You can see the data for Leeds divided into the least deprived and the most deprived. So the least deprived areas, the most affluent areas, are shown in blue, and there's barely excessive obesity levels. It's 5.8%, and it really hasn't shifted. However, in the most disadvantaged areas of the city, there's a dramatic reduction from 13.8% to 10.9% kids obese. And that fits nicely with the focus of the strategy to start in the most disadvantaged areas, and suggests that shift is possible. So, might HENRY be responsible for the shift? Well, who knows? I'd like to believe it is, but it's certainly not my purpose today to try and promote any one intervention. What I wanted to do was to reflect back and think about the intervention and what seems to be effective, and just seeing what lessons can be learned across from the experience. And then I want to go on and look at the issues of implementation, which actually we've also just heard from Sarah that's key to having any sort of effect, and looking at 2 different approaches to implementation across 2 different countries. So just tell you a little bit about Henry. It focuses on the very young. There's a strong focus on parenting, which I believe is probably the most crucial issue to be focusing on. There's the emphasis or issue that it's being rolled out primarily in disadvantaged communities. But beyond that, it involves partnership working, and this is absolutely core, is how practitioners work with parents, not only what they deliver. And Henry itself comprises professional training to work with parents both in groups and individually, and community involvement, this citywide, multifaceted approach. So what's happened so far? Henry's been operational in 70 regions of the UK. There's a national training team involving 22 trainers, and there's some local training teams in areas which have particularly adopted the programme, with 7 local training teams. They're running 90 training courses a year, and I was surprised to hear the latest figures, which is over 12,000 professionals have been trained in England in the approach, and over 8,000 have completed, parents have completed parenting groups. I'm less clear about the one-on-one work. Henry in Israel is very new. It was adopted by the Ministry of Health, and the aim was to have a national obesity prevention programme with a 5-year pilot in both Arab and Jewish cities, focusing first of all in the most disadvantaged communities. There were just 4 trainers. They've only run 15 training courses, and so far there's just in the hundreds the number of people who've benefited from that. Perhaps I should, well, no, I won't now. Okay, so what is the essence of the intervention? It was largely built following a fellowship I had the privilege to do in the Centre for Disease Control in Atlanta, Georgia, where I looked at all the possible evidence that might influence lifestyle in the early years and its tracking into later life. And the 5 topics that I took as being the key topics to work on were parenting, eating behaviours, nutrition, physical activity and screen time, and emotional well-being, and sleep has now been added as an additional. But as important as what you're delivering is the messenger who delivers the programme. And working on the psychology literature, that the core skills that messengers need to have are empathy, warmth, and genuineness to be effective as messengers. And lastly, the actual approach was partnership working, essential not to be experts to parents, but to work in partnership to come up with solutions, to focus your intervention on those solutions, and to have practitioners reflecting back on their practice in order to improve their skills. So here come the 4 Ps, and I've actually inserted a 5th P. Let's look at policy, practice, professional competence, and parents, and of course the spin-off onto their children. And what I'll present here is a mix of results from an in-depth study involving 77 parents who were followed over a 6-month period, having done a 2-month parenting group. And then the national data collected by Henry, which to date, at the time it was analysed, involved over 1,100 practitioners, and also a professional e-survey which followed the practitioners up over 4 years to see how they felt about the experience, the training, and the issues they had in working with families. So let's start with policies. And this was very interesting because the approach within children's centres was to train the entire staff of a children's centre. And you'd expect perhaps the nurses and dietitians and so on to be trained, but it went right down to the people who were preparing coffee and tea. And I'm not sure about the cleaning staff, but it was they were trained as a group, as a team together. And I think that's absolutely core to getting messages across. And the follow-up showed that there had been change in policy in the children's centres, seen by interviewing the managers and also interviewing the various staff who were working there. Regarding mealtimes and eating behaviour, there was now family-type eating with self-service, so that children could take their own food, which seems to be related to them being more reasonable than when food is piled on the plate. Portion sizes had been changed. That's always stunning to people to hear how little children need to be served in the first part. They'd bought in smaller serving spoons and plates, which definitely reduces one's concept of eating, and encouraging children to recognise their fullness cues rather than always piling on second helpings onto children's plates. They'd brought in healthier meal and snack time items, and the kitchen staff had been involved in this endeavour. Physical activity, in this part of the world it's not so easy because getting kids out to play involves putting on coats and boots and what have you, but there was an increase in physical activity, and many of them had developed not expensive but new equipment and resources to encourage active play. And there was an emphasis on role modelling, which I'll come on to in a minute. So that was the first P, policy. The next double P is professional practice, and in analysing results of questionnaires, and also by putting comment boxes in the children's centres, we found that professionals had greater self-confidence in tackling the issue of obesity and in how to work with parents. In a long-term survey, some of them were 4 years after the training, we asked them to highlight what they thought was most important in terms of their new way of working around obesity prevention. And interestingly, it was not, maybe not interesting, it wasn't nutrition, it wasn't physical activity. What they highlighted as being the most important things that they'd gained was the importance of empathy and parenting skills. So it's not what you're doing as a parent, but it's how as a parent can you improve your efficacy Okay, next was role modelling. They saw that it was hugely important that they role modelled to parents what was required. And what was amazing was the change in culture in children's centres, and we've got a whole series of quotes on how people were bringing healthier food into themselves, for the staff lunch times, of how they were out being more active themselves, and they saw that as being an important way to help parents change. And the next P, the unexpected P for me, was professional personal lives. I mean, this was a professional training. There was no real emphasis on what are you doing yourself, other than to highlight that being a role model is important. But there were substantial changes that practitioners made themselves, and saw that this was an important outcome of the training. And when you consider that the NHS in England is one of the largest employers, and I gather the data shows that some 40% of staff working within the NHS are overweight or obese, that even if that was the only outcome, it has some substantial public health effect. So next, the ultimate target, parents and young families. And this, as I say, was taken from an in-depth study of 77 parents across 12 different groups, and then the standard routine data that Henry collects, which showed improvements in all of the following, which is very gratifying. Parental skills and self-efficacy, huge. I think that was the most encouraging change for me to see. And we were talking about resilience in our small group earlier this morning, and some of the research I was doing in Israel showed that parental self-efficacy is actually the most significant resilience factor that we could find in families who had somehow protected themselves from obesity. Parents scored that their family health generically had improved. There were changes in what foods were in the home, changes in eating behaviour in the home, so there were more family meal times and less television on in the home during meal times. Children's and parents' nutrition improved in all the ways that, this was self-report, remember, I don't want to get too excited about it, but they did report that there was a reduction in sweets and sweet drinks, increased drinking of water, increased fruit and vegetables. That particularly parents' physical activity had increased, and that children were going out to playgrounds more, being taken to playgrounds more, and there was an effect on parental TV viewing as well. So it seems to be having the desired effect. So that was experience across England. Let's turn to Israel, which, well, before I do that, I should say that Henry in England is it's an NGO which worked very hard to get commissioned to deliver by local authorities and health teams across the country. Israel's taken a different initiative. The Ministry of Health has decided to adopt Henry on a 5-year plan and piloting it in 5 Jewish cities, 5 Arab cities, and then moving on to some other pilot areas, and have selected towns and local authorities for the lowest socioeconomic status. They're focusing particularly on children at risk once again, and I have to say progress has been rather slow, much too slow for my liking, and I think it illustrates the difference between having a top-down approach where people are told what to do, rather than the sort of more bottom-up gaining ownership that Henry in England has done. But 5 pilot sites have completed a year. Those are all in Jewish cities. Everything was translated into Hebrew. It's now all been translated into Arabic and is about to go into Arab communities. Most exciting is the city of Jerusalem, which is a hugely challenging place, as you're probably aware, but a decision has been made to train all the professionals in the Henry approach and focus on 2 neighbourhoods to have really in-depth work going with parents. And the aim, goodness knows whether it will take place ultimately, is that if this pilot is successful, that it'll go into all the infant and mother clinics across the country. So what does this all mean for obesity prevention? I am convinced that a citywide initiative is the way to go, that you need people pulling together across all the sectors to have a concerted effort to reduce obesity. And I still believe that the early childhood years, the 0 to 6 years, are the time to focus on. In talking various places, I'm very conscious of this debate between individual responsibility for obesity and the political responsibility. And I was actually shouted down in the United States, like, what are we listening to this working with individual parents? We shouldn't be doing it. It has to be all at the social, political level. But I do see that you need to have both sides coming in together. I don't believe that you can just make political change, and that seems to be even harder than the individual change, I think, without addressing the individual too. Practitioner skills and approach, that's absolutely core. That, if nothing else, I think when people are trained in this sort of approach, they realise that they've been all their background training is in being an expert, and doctors are probably the worst, followed by dietitians. But we preach, we tell people what to do, we don't do enough listening, and we don't do enough allowing parents themselves to come up with the solutions to make changes within the family, and that's a much more effective way to do it. Parental self-efficacy, parenting is hugely important. I would say it's almost universal that at the time of birth and pregnancy, that all parents want their child to grow up healthy and without obesity problems. And it's hugely, the problem is they lose the plot because it's so difficult to be a parent, and that if we can improve people's parenting skills, particularly around the issues of lifestyle, that's the way forward. Lastly, just something to insert something slightly different, is that we've done some work around resilience in Israel, really intrigued by those families who, despite all the odds, land up having slim children, and trying to understand that the positive factors that we should be going for. And perhaps it's no surprise, but it very strongly came out that if you're obese and you're socially disadvantaged, if you have reasonable levels of maternal education, I'm only talking about high school education, your children are protected. So that those who'd finished high school early, there was 40% obesity amongst the children at the age of 5, and yet those who had completed high school, the levels of obesity were much less, down at I think 20% plus. So it was a very strong message that maternal education, girls' education, is important also in the area of obesity. And lastly, I do think that the National Child Measurement Programmes, collecting the data, can be hugely useful in terms of monitoring what's happening, particularly as obesity intervention trials are so massively expensive. I think we can learn a lot by routinely collected data and interpreting it intelligently. So, thank you, and just to acknowledge. Thank you very much.